Good evening, students. This is Dr. Herndon. I'm going to be recording chapter 32 for you. We're going to be covering this on Tuesday in class, and I wanted you to have a recording so that if you choose to, you can review this recording either before the class or after the class or before your test number 3. So this content will be on test number 3. So again, this is chapter 32. It's all about women's health care. It's got a lot of good information, excuse me, for women's health care. And these are your learning objectives. And these are listed in your text. And this is learning objectives continued, listed in your textbook. And these are the last of the learning objectives listed in your textbook. And so this slide speaks to the National Heart, Lung, and Blood Institute study that began in 1991. And this this study just brought out specific focuses on preventive health care for women, for postmenopausal women, and these focuses included cardiovascular disease, breast cancer, colorectal cancer, osteoporosis. So all of these were in the study, and this is what we focused on, and we still focus on these today for our goals that we want to keep for women, and that they are included in the Healthy People. But again, this study began in 1991. You may have test questions on this. Began in 1991 by the National Heart, Lung, and Blood Institute and started as a 15-year national study, and it did focus on prevention for cardiovascular disease, breast cancer, colorectal cancer, and osteoporosis for postmenopausal women of all ethnicities and socioeconomic backgrounds. And this chapter includes information on breast cancer, on cardiovascular disease, and osteoporosis. The Healthy People 2030 now has released many new health topics that the nation will focus on as well, now toward going forward to 2030, such as reduction in obesity, reduction in breast cancer rates, increase in breast cancer screenings, and increase in cervical cancer screenings, and also increases in colorectal cancer screenings. And all of this also is helpful if we have an increase in genetic counseling for breast cancer and ovarian cancer, because some of these genetic factors place women at a predisposed risk if they have certain genes, the BRCA gene. So also included in the 2030 Healthy People 2030, we have a goal to decrease in the number of women who develop osteoporosis after age 50 and reduce hip fractures in women. So the hip fractures are very common in women, postmenopausal women, because we lose our bone density, and then we may fall, or we may break a bone and then fall. So we need to really know these things, and focus on these things, and have these in the back of your mind, because your patients will need to know these things as well. So they're going to be looking to you to teach them about preventive care. Also, we have increases in the number of young women who are screened for chlamydia, and we have increased chlamydia rates, and increased gonorrhea rates along with chlamydia. And I believe we spoke on that in chapter 31. But your 2030 objectives also focus on this. We want to increase the number of young women who are screened, excuse me, for chlamydia and reduce the incidence of pelvic inflammatory diseases in these young women. So we know that chlamydia is a culprit for women who have developed pelvic inflammatory disease, and we want to make sure that that number decreases, because that, as we have learned, this produces scarring tissue and that produces infertility in women. So for health maintenance, health maintenance in women for women refers to early detection of diseases through recommended screenings for certain diseases. Many women wait to seek health care when they have problems. So it is very important as nurses that we know the recommended guidelines for preventive screenings, such as the breast cancer and cervical cancer screenings, but also for cardiovascular disease and colon cancer. So we know that a couple of years ago, maybe 5 years ago, we moved colorectal cancer screenings from age 50 for the first one back. We pushed it back to age 45. And if you've had a close relative that has been diagnosed with colorectal cancer, then you would be needing to do that screening earlier, and your doctor has recommendations for that um, based on your history. But so those are the preventive screenings, some of them, and you can look on figure 32.1 in the textbook. Based on the risk factors, additional screenings and tests include bone density screenings before age 65, and STD screenings, all kinds of STD screenings, HIV testing, and then we have the lipid profiles, the fasting glucose test, rubella antibodies, and we want to make sure that we're immune to rubella. Thyroid stimulating hormone test is one. Genetic screening for reproductive cancers such as ovarian cancers, and also TB testing and sigmoidoscopy every 5 years, or colonoscopy every 10 years. So that's your colorectal. And they do have other tests as well that um, you can do before the in between the years that you do the sigmoidoscopy or the colonoscopy. But the colonoscopy is done every 10 years for the general public, the general population. And so we know that colorectal cancer and cervical cancer are both preventable. Cervical cancer is preventable if you have the pap test and the high-risk HPV testing done. And then, based on those tests, you can have screenings to see if you're positive for certain HPV strains. And if you are, you can be treated so that you don't develop cervical cancer. There still are women that develop cervical cancer, and unless it's caught early, they still do die from cervical cancer, which is a shame because it is a preventable cancer. Also, the colorectal cancer is preventable because if you have your colorectal screenings and your colonoscopies or your sigmoidoscopies, then you can identify polyps, and those polyps can be removed and tested to see if they're if they're precancerous or if they're cancerous, and then that can be treated so that you do not develop a full-blown colorectal cancer. So that's very important to know. Okay, so there are 4 common benign disorders of the breast, and these are fibrocystic changes, and this occurs during the reproductive years. Fibrosis or thickening occurs in early stages, and then cysts may form later. And these are felt as multiple well-delineated nodules that are tender and movable. So this is your fibrocystic changes. They are lumpy, they're rubbery, and they're rope-like. And they're nodules that vary in size from 1 to several centimeters in length. And this was called fibrocystic disease earlier. But since this is so common and it is not considered a disease, it is referred to as fibrocystic changes now. So this is a change in the way we have, named this disorder. And it's because that it is so common, we changed the name and now we just call it fibrocystic changes. Treatment for this is based on symptoms. First-line options are based on lifestyle changes, reducing caffeine intake, chocolate, and wearing a supportive bra. As this has been the top recommendations in recent years. And if these do not help, NSAIDs or contraceptive pills many times are prescribed for these. Fibroadenomas are the most common benign tumors of the breast, and they can occur during the teenage years and the 20s. And these are composed of fibrous and glandular tissue. They are firm, they are rubbery, freely movable nodules, and may be tender at times. And they're most often found in the upper outer quadrant, and there may be more than one found. Treatment can be careful observation for a few months. Persistent symptoms require mammogram and ultrasound, and the risk for cancer is increased with fibroadenomas, and they may require fine needle aspiration or core biopsy may be used as diagnostic tools just to rule out the cancer. But the problem with this is that they're lumpy and bumpy, and we don't really know if they're cancer or not, and we could overlook a cancer if we know a woman has this. It's easy to overlook this. So ductal ectasia usually occurs at menopause, and it is characterized by dilation of the collecting ducts that become distended and filled with cellular debris, and this initiates an inflammatory response, and the result is a mass that feels firm and irregular, an enlarged axillary node and nipple retraction, and the woman may experience pain, and she may experience discharge. So a biopsy is required to rule out breast cancer because symptoms are similar to breast cancer. And these ducts may be surgically removed to prevent further discharge or to remove an abscess that results from the infection. And then you have intraductal papilloma. This develops just before or during menopause. Usually occurs under the areola, where the papilloma or small elevations or protuberances develop in the epithelium of the ducts of the breast. As a papilloma grows, it causes trauma and erosion within the ducts that results in serosanguineous discharge, and that just means that it's liquidy, but it's bloody. It's blood tinged discharge from the nipple, and so the treatment for this includes excision of the mass and ductal area and an analysis of the nipple discharge to rule out malignancy. So we have to look at that discharge. We have to do cultures on it, and we have to study it to make sure that we rule out malignancy. Regular follow-ups are done to identify early breast cancer if it develops. And so we want early detection so that we can treat early, and the woman has less problems if we find it early and we treat it early. All women feel anxiety when a breast abnormality is found, and it may be helpful for women to know that most findings that are found are benign. The nurse will be able to reinforce medical explanations of a diagnostic test and how long the woman will wait for the results. So of course we don't, as nurses, we do not give the diagnostic test results. The doctor does that. And then, so I want you to look on box on the box 32.2 on page 699 at the top. Risk factors for breast cancer are, of course, female, age. Well, we have the older the woman gets, the more at risk she becomes. For women ages 55 and older, we have 1 in 8 invasive breast cancers in women younger than 45, and 2 of 3 women aged 55 or older will develop breast cancer at some time in their life. So race, we have more white women that develop breast cancer, but more Black women are likely to die from breast cancer because they tend to develop more aggressive cancers, and also sometimes they don't go to the doctor as often, they don't get screened as often. Those are the reasons. So Asian, Hispanic, and Native American women have a lower risk of developing and dying from breast cancer. Early menarche, less than 12 years of age, or late menopause, greater than 55 years of age, these scenarios pose a risk due to greater exposure to the hormones estrogen and progesterone. So we have a greater risk if we have our periods early and if we have our menopause later of developing breast cancer. White women, as I said, have a higher incidence overall. Non-Hispanic Black women have a higher incidence before the age of 40. Black women have a higher mortality rate from breast cancer because of having faster growing tumors and being diagnosed at a more advanced stage frequently. This is frequently what occurs. Your Asian American and Hispanic and Native American and Alaska Native women have a lower risk for developing breast cancer than white or Black women. Genetic mutations such as BRCA1 and BRCA2 increase a woman's risk of getting breast cancer, and mutation of CHEK2 gene increases breast cancer risk in both men and women. Women who never give birth or those who delay pregnancy until age 30 or longer have a greater risk of developing breast cancer because of the increased exposure of estrogen over her lifetime. Also, as indicated in box 32.2 on page 699, women who have previously been irradiated of the chest area as a child or young woman as treatment for another cancer such as Hodgkin's disease or non-Hodgkin's lymphoma, and also previous abnormal breast biopsy results such as atypical hyperplasia. All of these increase the risk by 4 to 5 times. Fibrocystic changes without proliferative changes does not change breast cancer risk. But again, if they have those changes, it's harder to detect an abnormality if they have one, if it develops. Long-term hormone replacement therapy with estrogen and progesterone and excess alcohol consumption and also obesity or being overweight and physical inactivity, these all increase the risk of developing breast cancer. And there are many treatment options from many disciplines for women who are diagnosed with breast cancer. A combination of surgery and adjuvant therapy, additional treatment, is recommended most of the time, and there are many types of surgery. Breast conservation surgery involves lumpectomy of the malignant tissue to reach the clear margins of the healthy tissue surrounding the tumor. The lymph nodes are usually removed to identify the stage of the cancer. Quadrantectomy is more extensive, removing a quadrant of the breast tissue, also removing lymph nodes for staging, and the simple mastectomy removes the entire breast, but not all of the axillary lymph nodes. Staging is also done with one or some of the lymph nodes And then modified radical mastectomy involves removal of breast tissue, axillary nodes, and some chest muscles. So that is a radical mastectomy. And then your sentinel lymph nodes, or CNL biopsy. This is a technique used to remove a smaller number of lymph nodes, a small number of lymph nodes for evaluating cancer spread by evaluating the closest one or two nodes, and can reduce we can reduce the nodes removed, which can decrease the lymphedema that affects some women. And these days they're using this less often. They may remove one or two, but they don't remove more than that usually, unless there's a good reason, because it cuts down on that lymphedema, the swelling that occurs, because the lymph nodes are there to receive the lymph and get it back, uh, into the circulation of the blood. So if we remove a lot of those, we just have a problem. Women have a problem with swelling, and it's hard to get that swelling to resolve. So adjuvant therapy is supportive or additional therapy that follows a surgical procedure, and this can be radiation therapy or chemotherapy or hormonal therapy and immunotherapy. Radiation therapy minimizes the chances of spread or recurrence and uses high energy rays to destroy cancer cells. The effects are like a sunburn. Intensity modulated radiation therapy is a newer technique used to deliver precise doses to precise areas. And chemotherapy uses a combination of drugs designed to kill the growing cancer cells. So rapidly dividing cells are also killed during chemotherapy, like the cells of the mouth or the hair, but these regenerate. So side effects are loss of hair, nausea, anemia, reduced clotting factors, and reduced immunity. So hormonal therapy, this includes estrogen blocking medications. They may be prescribed because the cancer may be estrogen receptor positive, where cancer growth is increased by estrogen in the body. And these estrogen receptor positive tumors occur in premenopausal and postmenopausal women. Osteoporosis is a greater risk with women who are taking estrogen blocking medications. Tamoxifen is a common hormone therapy that blocks estrogen, and the immunotherapy, which is biologically based therapy, targets specific cell pathways that promote cancer growth. About 25% of women with breast cancer have tumors that overexpress HER2, a protein that promotes breast cancer cell growth, and trastuzumab or Herceptin and pertuzumab or Perjeta are monoclonal antibodies that are given to patients to reduce the overexpression of the protein HER2. So that's important to know as well. So there are many things that can, that can help women now. Many medications that we have now. We have a lot of research and a lot of medications that have been developed based on that research that can help women have very good prognoses, and the 5-year recurrence rate is very low when these are used. And then we have breast reconstruction. Reconstruction options are discussed during the treatment planning, and the timing, usually it's right after, immediately after the breast surgery. This helps the woman feel normal again. And some treatment strategies make it best to wait for reconstruction until after the initial breast treatment is completed. Waiting also allows the woman to consider all of her options for reconstruction And waiting gives the woman time to heal from the surgery and time to consider her personal values and desires regarding another surgery. And some of the methods include tissue expansion method. This uses an empty silicone implant fitted with a valve that can be accessed by percutaneous needle puncture. Um, and the bag is filled with saline in small increments to slowly expand the tissue. And then when the desired volume is attained, the incision is reopened and the device is removed and the expander is exchanged for the implant uh, of the uh, of the breast that is the reconstructed breast that is implanted. In some models, the valve is the only part that has to be removed, and the expander itself is the implant. So they're just are very different. There's a lot of different strategies that can be used. The tissue flap procedure removes or uses autogenous tissue. That means the woman's own tissue from the back or the abdomen or the buttocks to create a large mound. And this procedure involves two incisions, one at the breast and one at the site of the donor tissue, either the thigh, the buttock, um, the tummy, the adipose tissue of the abdomen. And women with diabetes and connective tissue disorders and women who smoke are not candidates for the tissue flap procedures because these procedures involve altering the blood supply to transplanted tissues, and there would be a possibility for wound healing with this. And so the diabetic woman would not be a good candidate for this, or the woman with who smokes, because smoking constricts vessels and it does not allow um, the blood to nourish those areas. So there are other conditions that have to be considered too for other elements or other disease processes, but you can probably guess at some of those. So thin women do not have enough tissue for transplant tissue to the breast, and there are 4 different types of flap procedures depending on where the donor tissue is taken from on the woman's body. Um, you can look at page 700 and read more about this. And the nipple or areola reconstruction improves the natural appearance in the reconstructed breast through a small skin graft. And after tissue has been grafted, tattooing is done to make the area look natural. So there are a lot of technology that goes into rebuilding a breast and reconstructing a breast. And it's very interesting. The time from diagnosis to the treatment of the breast cancer is the most stressful for the women, and factors that contribute to pre-surgery distress include uncertainty, inadequate information, and the need to make difficult treatment decisions and um, scheduling for problems, and consultations are needed with multiple specialists such as a surgeon, a radiotherapist, a plastic surgeon, and a medical oncologist. And if the specialist has conflicting opinions, the woman feels frustrated. So uh, they usually work in teams, and this is a very good strategy. And it just it's very it's when the doctors work as a team, it's very reassuring for the woman and very supportive of the woman undergoing breast cancer treatment. Um, so some of the concerns of women who are diagnosed with breast cancer are fear of recurrence and fear of death, and uncertainty of quality of life after the treatment, changes in her body image, effect on sexuality, and side effects of therapy. Many women have a big fear of losing their hair. Significant others may also have problems. Um, the women may have sleep disturbances, and her significant other may have have sleep disturbances. Also, eating disorders, problems with work responsibilities, all of these impact the couple. And the marital relationships may be strained primarily in the area of sexual relations and communication about matters related to the illness. Some women want to discuss these matters, and other women, including the male partners, may feel that the discussion is focusing on negative aspects of their relationship, so they don't discuss these. We need to look at, you need to be familiar with box 32.3 in your textbook on page 702. Heart disease is the leading cause of death in the United States for women. And in the year 2017, 1 in 5 female deaths were attributed to cardiovascular disease. And this includes all disorders of the heart and the blood vessels. It includes myocardial infarction, congenital abnormalities, and stroke. And women many times do not recognize cardiovascular disease as women's number one killer. Symptoms can be very different from men's symptoms of cardiovascular disease. So women have smaller coronary arteries and less collateral blood vessels than men. And when I say collateral, that means that the vessels that are blocked or sluggish may grow new vessels and take detours so that the tissue is still nourished. And so this is a remarkable thing that happens in our bodies when our bodies are capable of creating collateral blood vessels, collateral vessels that are able to do what the old vessels can no longer do. So because of the more vague symptoms in women, diagnosis and treatment is often delayed because they're often misdiagnosed and we think it's something different. Symptoms may be substernal chest pain instead of a very big weight on the chest that's a crushing chest pain. It's not like that most of the time for women, but they do have shortness of breath on exertion, and they have atypical chest pain. They have fatigue. They have neck, shoulder, or back pain and lightheadedness, and palpitations and diaphoresis and nausea and vomiting. So they may have a lot of they may have symptoms that are comparable to GERD. And then we'll talk more about this in class, and I'd like to see if you have family members, or if you know of other people, other women that have had this and what their symptoms were. I'd like to talk about that in class. But for right now, prevention, controlling hypertension is big, is key. Page 702. I want you to know the blood pressure normals. I want you to know what is considered elevated and what is considered hypertension stage 1 and stage 2. So you need to know that. And we'll talk about this. I'll ask you this in class. What does this mean? We need to have women to stop smoking. Smoking is a big red flag that problems are ahead. And then we need to control our diet. We need to control our glucose level. And we need to increase activity. A low dose aspirin, 81 milligrams, or baby aspirin is beneficial to decrease platelet aggregation. And so that's what we usually see women being prescribed. And then we want to talk about the menstrual cycle disorders. All menstrual cycle disorders require comprehensive gynecologic assessment. Nurses should be knowledgeable about these underlying processes and diagnostic procedures and treatment regimens in order to be a patient advocate, to provide education and support through patient counseling. And amenorrhea is the absence of menstruation. And this is normal before menarche, usually beginning at 12 or 13 years of age. And it's normal during pregnancy and during the puerperium and lactation period, and then it's also normal after menopause. So those are the times that amenorrhea is normal. Amenorrhea at other times is abnormal and is either primary or secondary amenorrhea, depending on when it occurs. If by age 15 a girl has not begun menarche in the presence of normal growth and secondary sex characteristics, this is called primary amenorrhea. Primary amenorrhea is also considered at age 13 years if onset of menstrual periods have not occurred and there is an absence of associated sexual characteristics. And the most common cause for primary amenorrhea associated with the absence of breast or pubic hair development is Turner syndrome. And I believe this information may overlap in your pediatric lectures. So Turner syndrome, that is when girls have only one normal X chromosome. And primary amenorrhea is a girl who has secondary sex characteristics, can result from incomplete development of the uterus, ovaries, or fallopian tubes. So intrauterine exposure to diethyl stilbestrol is associated with abnormal development of the uterus. Diethyl stilbestrol is a synthetic form of the female hormone estrogen prescribed to pregnant women from 1940 to 1971 to prevent miscarriage and preterm labor. Studies in the 1950s showed that it was not effective for these problems, although it continued to be used to stop lactation and for emergency contraception and to treat menopause symptoms. So that was something that was not good that they knew about, that they didn't stop women from using this drug, and they used the drug for other things. They knew that it was causing some problems. They knew it in our country and other countries as well. But it was stopped. The use of it did stop in 1971. So we asked that question in our health histories, if the woman knows that she was exposed to this drug in utero, because there are still women that were just, they were exposed to this as a fetus that are now still living. So we have to leave that question in the health history until we think that there aren't any more still living that could have been exposed to that. But researchers did link this drug exposure to a type of cancer of the cervix and vagina. We now know that DES, and this is what we call it, diethyl stilbestrol, we call it DES. We now know that DES is linked to cancer, birth defects, and other developmental abnormalities. Secondary amenorrhea is the absence of menstruation for 3 months or more in a woman who has established a regular pattern, and 6 months in a woman who had established an irregular pattern of periods. So in addition to pregnancy, the possible causes include diabetes mellitus, tuberculosis, hypothyroidism, and central nervous system lesions. Also, hormone imbalances, strenuous aerobic exercise, poor nutrition, the use of hormonal contraceptives, and ovarian tumors can cause secondary amenorrhea. Events such as divorce, the death of a close friend or family member, moving, these things can be very traumatic for some people. Job change can result in stress associated with secondary amenorrhea. And assessment for the secondary amenorrhea includes a thorough medical and obstetric history and laboratory testing of hormone levels, questions about stressors in their life, eating habits, history of dieting, and current exercise pattern. Also, assessment of use of drugs such as hormonal contraceptives, phenothiazines, the phenothiazines, such as antipsychotic medications used for the treatment of schizophrenia and bipolar disorder, and the control of nausea and vomiting, and other psychotic disorders with delusional manifestations. Also, antihypertensives, which can cause secondary amenorrhea at times and with some drugs. And the intervention aims at identifying and correcting the underlying cause that the treatments will vary because of different underlying causes. So excess androgen levels may be linked to polycystic ovarian syndrome, PCOS, which can be characterized by acne, excess weight, and body hair, and anovulation that result in amenorrhea. Abnormal uterine bleeding occurs with abnormal frequency and lasts an abnormal length of time, occurs irregularly, or is excessive in the amount. Most abnormal bleeding occurs in cycles without ovulation. It occurs near puberty and perimenopause. Spontaneous abortion must be considered with this. Uterine cancer must be considered in women with postmenopausal vaginal bleeding. So if a woman has went through menopause and she has stopped bleeding and she has not bled, she has not had a period for 1 year, and then she starts bleeding again, bright red blood, this is a concern. It may be concerning to the physicians that she may have uterine cancer. A common cause of abnormal uterine bleeding falls into 5 basic categories. Number 1, pregnancy and complications and spontaneous abortion. Number 2, anatomic lesions, benign or malignant, of the vagina, cervix, or uterus. Number 3, drug-induced bleeding, such as breakthrough bleeding with birth control pills. Number 4, systemic disorders such as diabetes mellitus, uterine myomas or fibroids, hypothyroidism, blood coagulation disorders. And then number 5, failure to ovulate. And management should be pregnancy tests, coagulation studies, tests to see if ovulation is occurring, and then your hormone and liver function tests, plus tests to determine if anemia is a factor. Because if she's bleeding a lot, then we have to test for anemia. Ultrasounds or hysteroscopy may be done to check for polyps and examine the uterine lining. A common treatment is progestin estrogen combination oral contraception or oral contraceptives that suppress ovulation and allow a more stable living lining to form in the uterus. And then surgical therapies include laparoscopy and possible dilation and curettage to remove polyps or to diagnose endometrial hyperplasia. A hysterectomy may be performed if the uterus is enlarged and the woman does not plan to have more children. And then we have laser ablation that can also be used to permanently remove the endometrial lining without a hysterectomy. If a woman is anemic, this will be treated as well, and nurses can advocate to these women. It's good that you know all about this because women want to talk about it and they want you to know about it. So we can advocate for them, encourage them to seek medical attention for irregular and prolonged bleeding, and nurses can help women to keep a record of their bleeding episodes and the amount of blood loss. And this is done through counting pads, saturated or tampon saturated, and the nurse teaches the woman about adequate nutrition and discourages rigorous dieting and exercising and reduces stress in her life. And the nurse provides support for the woman with these problems by providing information about the diagnostic procedures and tests that are helpful in the diagnosis of causative factors. So the nurse can do a lot. I want you to know about figures 32.2 and 32.3 in your text. Cyclic pain must be distinguished from acute pelvic pain, which could be indicative of ectopic pregnancy or appendicitis. And the most common causes of cyclic pain are Mittelschmerz, which is the pain that a woman experiences during ovulation. And some women don't even notice that, but some women do have pain from that. So it's described in your text. And uh, also dysmenorrhea, which are painful cramps during your period, and endometriosis. And Mittelschmerz refers to unilateral pelvic pain occurring midway between menstrual periods at the time of ovulation, and that is directly from your text. So I want you to know what that is, and because you probably will have a test question on that. This pain is caused by the growth of the dominant follicle in the ovary, or the rupture of the follicle and spillage of the follicle fluid and blood in the peritoneal space. And this pain is sharp, and it usually lasts for a few hours to 2 days. And a slight vaginal bleeding may accompany this discomfort. And cyclic pelvic pain can be primary dysmenorrhea with no definite known cause, or secondary dysmenorrhea associated with pelvic pathologic changes. Primary dysmenorrhea causes cramping pain with the onset of the menses, whereas secondary dysmenorrhea may not be cyclic at all. So pain with primary dysmenorrhea usually resolves over 48 to 72 hours, and some women, and not all women, experience this. Some women produce excessive endometrial prostaglandins during the late luteal phase of the menstrual cycle, and these prostaglandins, especially the E2, diffuse into endometrial tissues, and that causes abnormal uterine muscle contractions and uterine ischemia and hypoxia. So that's what's causing that pain, and so a lot of doctors feel that being active, that regular activity and being less sedentary will help this to level out. And so this process accounts for the cramping, uterine pain, and possibly diarrhea, and possibly nausea and vomiting. Oral contraceptives and NSAIDs provide effective relief by reducing prostaglandin secretion in the endometrial tissue. For best results, the NSAIDs should be started at the start of the period and taken around the clock for 48 to 72 hours, because these cramps are debilitating for some women, and they are real. They are not make believe. So once you have to get ahead of the pain and stay with it. So those hours, the round the clock, NSAIDs, that's important, that women follow that recommendation by their physician. And also, if they can remain active during the whole month, and remain active at all times, so that they can hopefully avoid some of this. So endometriosis occurs when endometrial tissue is present outside of the uterus, and this occurs in about 10% of women. It is often associated with secondary dysmenorrhea and causes chronic pelvic pain and infertility, and the causes remain unknown. One theory is that retrograde menstrual bleeding, or the reflux of this blood flow, backs into the fallopian tubes and causes these cells to attach to fallopian tubes and ovaries, and these cells continue to grow there. They're like live tissue, and so they continue to grow. And there is a possible genetic predisposition, and possible immunologic changes and hormonal changes that occur. Endometriosis is often diagnosed when the woman is in her 20s or 30s, and it can remain mild or it can become more severe. Figure 32.2 illustrates the most common sites for endometriosis, and it can be in a lot of different places. It can grow and just cause havoc inside the woman's pelvic cavity. So, two major symptoms are cyclic pain and infertility, and the pain may be unilateral or bilateral, and it may be sharp or dull. The pain usually begins 36 to 48 hours before menses, and dyspareunia, dyspareunia, this is painful intercourse. This is common, and rectal pain is also common during bowel movement. Treatment is either medical or surgical, and oral contraceptives are commonly used for this endometriosis if the woman desires pregnancy within 6 to 12 months. Depo-Provera can be used also. Estrogen antagonist or LISA, that was approved by the FDA in 2018 for mild to moderate pain in endometriosis. And liver function and bone mass density must also be monitored while taking these drugs. Surgical treatment can be performed to remove lesions when infertility is a problem. Hysterectomies sometimes are performed when the woman has severe pain and no longer plans to have children, and nurses can support the women by not dismissing the pain as just cramps. So this is something that's more severe than just regular menstrual cramps, and these women need support. They don't need to be dismissed by nurses because not all of us have experienced this, and so we really need to be sensitive to these women. Offer the woman suggestions for non-pharmacologic pain relief measures such as frequent rest periods, application of here to lower of heat to lower abdomen, and moderate exercise and a well-balanced diet. So again, if the woman can participate in a moderate exercise program, this has been studied, and it has been suggested that this can relieve a lot of problems with with this issue, as well as uh, just regular menstrual cramping. And also, as always, for healthy lifestyles, we need to avoid stress, and especially around the times of the women's periods. We need to avoid a lot of stress during that time. And the nurse should counsel the woman regarding side effects of medications used, the oral contraceptives or over the counter and prescribed drugs, and when to report these to her provider. And premenstrual syndrome or PMS, this is a group of symptoms. It includes a group of symptoms that occur in the second half of the menstrual cycle and cause varied types of severity and problems in a woman's work and relationships with others, because it causes emotional stress as well. And so approximately 90% of women are affected by PMS, and about 1.2% to 6.4% have more severe symptoms known as premenstrual dysphoric disorder, and symptoms can be severe anger, aggression, anxiety, depression can occur, as well as serious psychiatric effects that occur with premenstrual dysphoric disorder. So this is all important, and many times we don't think about this because we're so busy, and we don't realize that people are going through these things. But these things are very real for women, and we just need to be very, very sensitive to this, and be ready to counsel your patients about this if you're working in this area. Okay, so relieving symptoms of PMS. Page 706 has a featured box for how to relieve symptoms of premenstrual syndrome, and box 32.4 features the symptoms of PMS. An effective termination of pregnancy or induced abortion is a voluntary method of ending a pregnancy at the request of the woman that is not performed due to impaired maternal health or fetal disease. Therapeutic termination is performed to preserve the health of the mother, prevent the birth of the infant with severe birth defects, or to end a pregnancy caused by rape or incest. Elective abortions can be chosen due to economic or social reasons. Therapeutic and elective terminations involve many social and ethical issues, as you know. This is in the news a lot where we have, pro-life or pro-choice, and there are heated debates over these things, and we've had a lot of law changes. The overturn of Roe versus Wade happened a few years back, and now the states are in control, and different states have different laws. In 2016, the induced abortion rate was 11.6 per 1,000 women ages 15 to 44 years, which decreased from 2007. And then the Roe versus Wade was overturned in 2022, and the decision regarding abortion is now governed by each state. As I said, methods within the first 7 weeks of the last menstrual period, we have medication-based abortion techniques that are used for that gestational age, the first 7 weeks. And Mifeprex or RU486 is an anti-progesterone drug, and this is followed by Cytotec or misoprostol. Uh, and this is a prostaglandin drug commonly used it is used to reduce gastric acid secretions, and it is also used along with the uh, Mifeprex, or RU486. Oral or vaginal misoprostol follows in 48 hours to promote the expulsion if the pregnancy has not ended. And then we have methotrexate, Folix, and Mexate. This is an anti-metabolite also used to treat certain types of cancer, but it is also used for abortion. And this drug has not been approved by FDA for medical abortion, but is being used in small doses for medical pregnancy termination. It's rarely used in the U.S., but it is used in the U.S., but it's rarely used in the U.S. And surgical abortion techniques are used in the termination of pregnancy of women greater than 7 weeks since the last menstrual period, or if the medical termination has failed. Through the 12th week of gestation, vacuum aspiration with curettage is the method used most often, and the cervix is dilated after locally injecting anesthetic in the area, and a plastic cannula is inserted into the uterine cavity, and the contents are aspirated with negative pressure, and the uterine cavity may be scraped with a curette to ensure the uterus is empty. Cramping in this procedure may last 20 to 30 minutes after this is completed. Complications include uterine perforation, hemorrhage, cervical lacerations, and adverse reactions to the anesthetic agent. And for second trimester abortions, dilation with removal of the fetus and placenta, also known as dilation and evacuation or D&E, is generally performed. And this procedure is similar to the vacuum curettage, but it requires greater cervical dilation and a larger aspirator because the products of conception have grown in size and must be removed gradually. And the medical methods are available for abortion in the second trimester, but this involves labor, Retention of the placenta often occurs during some of these procedures, and if that occurs, it requires a DNC to fully clean the uterus. Laminaria are inserted approximately 12 hours before the procedure to start the cervical dilation, and prostaglandin, which stimulates contractions, may be given via vaginal suppository or intra-amniotic infusion. Oxytocin is not effective at starting labor because of the early gestation, but it may shorten labor after it has been established by other methods. Similar methods, okay, so if the fetal death has occurred in the second trimester, uh, this can be compared to uh, some of the abortion techniques. So if you've been involved in a fetal demise where they have delivered a baby that had died in utero, then you can some of these techniques may be used in abortions as well. So you can compare that. Because of the increased risk involved, elective termination of pregnancy is not often chosen in the second trimester. Nursing care is focused on providing physical and emotional support and information to the client. And the nurse will take a history and collect specimens for lab tests. Nurses should reinforce instructions about returning to the clinic and provide information for self-care. Nurses will provide teaching on signs of complications such as excessive bleeding or infection, and we need to counsel them that a temperature over 100 degrees Fahrenheit and foul-smelling vaginal discharge are signs of an infection. And then teaching on use of appropriate contraceptive methods afterwards is important. Rh negative women should be given RhoGAM, Rho-D, immune globulin, RhoGAM, if they do not have a pre-existing sensitivity to Rh positive blood. And on page 707, the guidelines for self-care after elective termination of pregnancy. These are important. You need to know this. Normal activities can be resumed, but strenuous work or exercise should be avoided for a few days. Bleeding or cramping may occur for a week or two. If bleeding or cramping becomes severe, medical advice should be sought after, and light spotting may occur for approximately a month. Sanitary pads should be used instead of tampons for the first week after an abortion to avoid infection, because those can, they can grow bacteria. They can harbor bacteria in that blood that's in that tampon. Douching should be avoided to prevent infection. Intercourse, intercourse should be avoided for 1 week after an abortion to avoid infection, so that the uterus and the uterine lining can heal. Birth control measures should be used if sex is resumed before menstruation begins, because it is possible to become pregnant again. Menstruation usually resumes in 4 to 6 weeks. And temperature should be checked twice a day to detect a possible infection. A temperature over 100, as I said earlier, should be reported to the provider, because that would be indicative of an infection. And attending the follow-up appointment in 2 weeks is very, very important. Your client should be advised of that, and they should be urged to not miss those appointments. Menopause means the end of menstruation, usually 2 consecutive months without menses, and the term change of life speaks to the entire process of the end of the reproductive period in a woman's life. And this includes the endocrine, the body, and the psychological changes that occur at the end of a woman's reproductive cycles. Premenopause refers to the early part of the climacteric before menstruation ceases, but after the woman experiences some of the climacteric symptoms such as irregular menses, and after a full year of no periods, that is usually the definition of menopause. So perimenopause includes premenopause, menopause, and at least 1 year after menopause. Postmenopause refers to the phase after menopause when periods have stopped altogether, usually after that 1 year. And once a woman is postmenopausal, vaginal bleeding should always be investigated as soon as possible because of the highly suggestive uh, risk of endometrial cancer if that does occur. Osteoporosis is an effect of estrogen deficit. And therapy for menopause. Some women seek assistance for the discomforts associated with menopause, such as hot flashes, interrupted sleep, or vaginal dryness. Um, there are estrogen and progesterone um, supplements to the woman who retains a uterus, and then estrogen for those who have had a hysterectomy. But there are adverse effects. There is increased risk for breast cancer and uterine cancer with some of these drugs. So we have to give the women all of the risk and benefits when we prescribe these as a as a physician or the nurse practitioner. And if you're the nurse, you need to know this as well. And then see figure 32.4 in your textbook about osteoporosis. This is it's increased spaces in the bone, and it increases after menopause. We need to have bone density tests done to look for this. There are drugs that can um, Fosamax is a drug that can counter the effects of osteoporosis, um, but it's caused because of the decrease of estrogen, and this decrease of estrogen it does accelerate the bone loss, um, and causes reduced bone density and the susceptibility to fracture. And sometimes the fractures happen and then they fall, or sometimes they fall and then the fracture happens. Um, so just read about this osteoporosis in your text and see the figure 32.4. And pelvic floor dysfunction. There's also a figure 32.5 and 32.6 in the text. You need to be familiar with this. This is just when either the vaginal walls prolapse and cause a cystocele, an enterocele, or rectocele, depending on the muscles that collapse into the vaginal vault. And then you also have a uterine prolapse that could occur, and this uterus actually protrudes through the vaginal vault, and women can feel it, and sometimes it even comes out of the vaginal vault. And a lot of times they can use a pessary, and this is spoken of in your text. It's just a device that is placed in the vaginal vault, and it keeps the uterus. It also can keep bladder prolapses from uh, being as bad, but a lot of women can't tolerate them. They're uncomfortable. Um, and so this is a something that you'll need to know about if you're working in women's healthcare. Um, but so just read about that. But uterine prolapse can cause urinary incontinence, or it can contribute to urinary incontinence because of the pressure and the pressure on the bladder. And something that can help prevent and help if it occurs are the Kegel exercises. Kegel or Kegel exercises, however you pronounce that, but it's just kind of like you're holding a marble with your vagina. They describe it as using the muscles to pretend you're holding a marble, uh, and then release it and do that. And you can do it anywhere, and no one knows you're doing it. But it also they also describe it as stopping stopping a urine stream and then letting it go and then stopping it again and letting it go. But there are many ways to describe this for women, so you need to practice this and it doesn't really matter the age of the woman. She can do these Kegel exercises for prevention, and especially if she's had a baby, these muscles need strengthening, and so she can use these exercises to prevent pelvic floor dysfunction. And so disorders of the reproductive tract, we have some benign disorders such as cervical polyps, uterine fibroids, which are, they're benign, but they do cause a lot of problems. They cause a lot of bleeding. And they will bleed a lot during periods, and sometimes they start bleeding and they won't stop and they have to be removed. And sometimes the uterus has to be removed. And then we have ovarian cysts that usually resolve with the menstrual cycle. When the cycle, we wait to see if it will resolve, and many times it will. But then there are some times when we have to intervene, when the OBGYN has to intervene. And then we have, of course, malignant. We have cervical cancer, and we've talked about that. We have endometrial cancer. We've talked about that. We can also have ovarian cancer, cancer of the ovary. So those are the malignant disorders that could occur. And the disorders of the reproductive tract, we need to always investigate irregular vaginal bleeding, unexplained postmenopausal bleeding, unusual vaginal discharge. This usually indicates, an infection, an STI, sexually transmitted infection. Dyspareunia. This is painful intercourse, sexual intercourse that is painful. We need to investigate this. And then persistent vulvar or vaginal itching. That needs to be investigated. And so read about those disorders. And then symptoms that must always be investigated are elevated or discolored lesions of the vulva. A woman can develop cancer of the vulva and persistent abdominal bloating or constipation, because that can be symptoms of ovarian cancer. And then persistent anorexia or vomiting. That can be symptoms of infection, of pelvic inflammatory disease, or a lot of different things. So we'll talk about that in class. And then blood and stools. So blood and stools is a red flag. It could just be hemorrhoids if it's bright red blood, but it also could be tarry, black stool, coffee ground type looking stools, and that could be indicative of a higher bleed in the GI tract, and it could be any of these bleedings could be signs and symptoms of a cancer, of a rectal cancer or a colon cancer. And then infectious disorders of the reproductive tract. We have candidiasis or yeast infection, which is very uncomfortable. It is also contagious. It's treatable. Usually the partner is advised to treat theirs as well, and not to reinfect the woman. But sometimes this is caused by just an imbalance of the normal flora in the vaginal vault, and also taking antibiotics can predispose the woman to yeast infections. So they're very, very itchy and uncomfortable. And then your sexually transmitted diseases, the moniasis, the bacteria vaginosis, the chlamydial infection, the gonorrhea, and syphilis infections, the herpes genitalis, human papillomavirus, HPV, acquired immunodeficiency syndrome. We've studied about this in chapter 31 in those slides, and I would just advise you to go back and refamiliarize yourself, and I think we're going to have a class activity about that as well. So just make sure you know all of these and know what the symptoms are and the causes and how they're contracted and the treatment. And then pelvic inflammatory disease, we have also talked about this at length. We know what the causes are, the scarring from the sexually transmitted diseases. We can get pelvic inflammatory disease from having multiple sexual partners and having an IUD in place, which opens up the uterus a little bit. That's how that IUD works. So we have to be careful when we have IUDs, but it is the infection of the upper genital tract. It does cause chronic pain, and usually the women who have this are in the hospital, and their their pain is being treated and their infection is being treated. It's a very serious disease, and they're usually hospitalized. So, and then toxic shock syndrome. This is a life-threatening condition resulting from infection with toxin-producing strains of Staphylococcus aureus. And contributing factors are or can be high absorbency tampon use and diaphragms that are not taken out when they need to be. So we need to be very careful, and we need to teach our women, our patients, about the use of these things and the reality of toxic shock syndrome and how that present and what symptoms to look for, and just making sure that they are knowledgeable about how to prevent that from occurring, and just making sure that you have a therapeutic relationship with your patients so that they're comfortable talking about all of these things with you. And thank you so much.